The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
I'm very pleased to be here to talk to you about why ICU should be involved. Now look, I'm a bit hesitant to tell you that when I was a medical student, this is what ICU looked like. Here you'll see the patient, the nurse in the funny hat, and the hats were very important in those days and highlighted exactly the seniority of the nurse. The MA1 ventilator that some in the audience may recognise with the bellows on the side, an enormous dead space and enormous tidal volumes for the patient on a trolley and not in a bed, and tiles on the wall and a couple of plugs. And that's what ICU was like just one generation ago. Things in ICU have changed dramatically, and I think the message for deteriorating patient response is that things are also changing dramatically and will continue to change. As we've heard earlier, it's not so long ago that the antecedents of cardiac arrest, deaths and emergency and ICU admission were identified, and that it was clear that 60% of these events had long physiological abnormality beforehand. I collected in my early days of medicine sheets and sheets and sheets, I still got them and I use them in teaching, of blood pressures that were 50 for 5 hours. I mean, I want to replace them because the students have handled them and they're getting tatty, but I can't because the way things have developed, I just can't find such horrific cases anymore. The studies of deteriorating patient systems haven't been profound in terms of deaths, but the message is clear. There's a clear small message in favour of survival in the introduction of deteriorating patient systems. But also, more importantly, the effect on cardiac arrest is significant. And cardiac arrests, avoidable cardiac arrests, are unforgivable. They're bad, as we've heard from the insurers. They're bad for administrations. They're bad for doctors. They're terrible for families and obviously appalling for patients. So it does seem that we actually have to do it to get an effect. So MET calls per 1,000 admissions, it's necessary to get up above 20 or so before you get an effect. So when we implement a deteriorating patient system, we actually have to do it. Half doing it is probably no good at all. And it's important to remember this when we try not to half do it. And within the study, when those of us who are in the field, we're constantly told that the MERIT study showed that it never worked and it's hopeless. The MERIT study did not implement effective deteriorating patient response. So hardly surprisingly, it didn't work. It's not a fault of the system, it's a fault that we didn't actually, in those days, we weren't able to transform. There's a time that it takes to implement the system and to get everybody calling and happy with it. In the early days, people were very resistant, and there were a lot of beaten up nurses who called MET calls. In my experience, that stopped, but it's taken a long time. Certainly, for me, in my early days, I mean, going back to that rather historic picture, at around the same time as that, in the early 70s, defibrillation had just started and everyone was wildly excited about the fact you could rush to patients and defibrillate them. And we had defibrillators on trolleys and we ran around the hospital defibrillating everyone. And, I can remember a day when there were six cases, all of whom were under 60, all of whom died. But, it was a lot of activity. And, of course, patients went to ICU and did terribly badly. This is the Austin data showing that the profound effect of introduction of deteriorating patient response and cardiac arrests dropping profoundly. I was interested in Robert's figures because we're actually a bit surprised when we get a code blue now. It's a remarkable event, not a daily occurrence. So which brings me to the model that I see as working effectively, the model of an ICU registrar with an ICU nurse going and assisting the person on the ward, who here is the surgical registrar. There's a ward nurse as well, but the ward nurse has just gone out to get GTM for this patient, and just as I took the picture, they ducked out of the door. But they're clearly an important part of the team as well. So a team, a collaborative approach appears to be, and I'll defend it this afternoon in the debate, the model, an effective model of collaboration. So I think we should just need to deal with a few little delusions and get them out the way early. So the first delusion is that the wards were really, really good at managing deteriorating patients before rapid response came up. They were horrific. I was there. All right? I can remember the faces and the names of patients who died when I was an intern of completely reversible things, and it was damaging. It was terrible. It was awful. And that was before everybody left the hospital, before all the specialists went off to their rooms and private, before everyone was doing procedures, including physicians. That was the good days, and we were terrible. So I think that's a delusion. The second delusion, it's really easy, and anyone can do it, or if you just train them a little bit, they could do it. But mainly it's because they don't bother and they don't care. I think this is very hard, and I'm going to argue later that there's a whole lot of important things to the response. So just sending someone and ticking the box that you've sent someone doesn't do it for me. You've actually got to go and do stuff and do it effectively. And it's bloody hard to teach people. Delusion 3. General medicine is thriving, and they're just itching to manage deterioration across the hospital. I don't think I need to say more. Delusion 4. Met is intrusive, unwanted, and de-skills. Well, here's data from Daryl Jones. Met cause reduced my skills in managing sick patients. The survey of nurses' attitudes to Met. Strongly disagree or disagree. Just about everyone. 1% strongly agreeing with it. 1% is not a majority. Met calls teach me how to better manage sick patients in my ward. Just about everybody. Where does this delusion come from? It's helpful, it's supportive, and in our experience it's exactly the same as this, that people in trouble like someone capable to come and help them. It's our dream to have someone capable come and help us when we're up it. So I think we need just to go through some of the things, of reasons why it makes it better. An ICU centralised rostered team has to be better than a hospital devolved system where they're not immediately available except for the intern. The most junior person is the most available. As you get up the capability, people are less and less available. And it's often a covering doctor because the other one, they're away on a half day or haven't turned up, I don't know. But it's always somebody, every time we go to Met calls, you know what it's like. They say, I'm just covering, I'm having a look through the notes, I've got no idea. A little experience with deterioration for the ward doctors. Job involves deterioration for us. Easy escalation for us. To nurse, to registrar, to specialist within ICU, we're all there. We're in the hospital. We're exclusively rostered. That's our job. Whereas getting support, from senior support out on the ward is really hard. I mean, I've done it as a medical registrar. As nurses, trying to get action outside the system is really, really hard. For the hospital devolved system, there's not much role modelling. When the medical consultants or the surgical consultants are there at the Met or are there in a deteriorating patient, they don't often make it better. They're often cause a bit more of a shambles than when the registrar's there. We can role model, and we can do it properly. The specialist role modelling, mentoring and feedback. I mean, I know we don't do it very well, and I'm talking about a perfect system, but, the idea that the specialist might go and show you how to do it sometimes and role model it would be wonderful. And mentoring and watching the registrar do it and giving feedback, that would be wonderful. We can do it. We should do it. We can do it. And, of course, airway stuff and resus is our core competency. Resus skills in the doctors out on the ward, very variable. You might be lucky, but, Christ, you could be very unlucky. The nursing support on the ward can be very variable. But, I mean, an experienced ICU nurse in the team is fabulous. You can't, as far as I'm concerned, I never want to be there without one. the resus diagnosis and action. We get there, we put resuscitation in place, we're working out a diagnosis, and we're working out our next steps. That's how we function. The hospital devolved approach can be all over the place, can focus on one thing. It's very variable. I'm not very confident about it. It goes further. Getting blood gases on the ward if you're a medical intern is hopeless. It'll take ages, you'll use the wrong syringe, you send it to the lab, it'll take an hour. It's just our bread and butter. Good radiology. When we ask for an X-ray, we get it now. When the intern asks for it, they'll get it next Thursday. Echo is now part of our service. Echo is an increasing part. It goes out on our Met call. It should go out on everyone's Met call. In a few years, it will do. It's changing. Where's the echo for the poor guys on the ward? They haven't got a hope. They've got to refer to cardiology and get one tomorrow. The high-flow, non-invasive CPAP drugs, there's a whole load of things, none of which the poor people on the ward have got a hope of. ICU is often remote and scary to them. I can remember trying to refer patients to ICU. It was horrible. But seamless ICU access when you're actually part of the team. Audit and review and quality improvement, owning the whole service, we can do it. If it's devolved to several people, there's generally been no audit, review or improvement. There's no leadership out there. They're on their own. We've got a clear governance structure. We're there. Patient-centred end-of-life decision-making is a huge part that I'll come to. That in the wards, our medical patients, we looked at good, goal-directed decision-making for patients at the time of deterioration. And the medical patients, it's below 5% in our hospital. I doubt yours is greatly better. So, urgent sorting out what we're going to do is a major part of the deteriorating patient system. So for me, it's chalk and cheese. There's no argument. For us as well, we looked here at the patients referred to ICU. So referred to ICU meant patients referred as urgent patients from ED, from the ward, and Met calls. So what do we find when we look at all these patients? A life-limiting illness. Now, this was the gold standard thing from the UK. So this is patients that the palliative care people in the UK think should be referred to a palliative care physician. So it's not wussy stuff. You're not looking all that good when you've got a life-limiting trigger. Okay, 2/3 of patients who are referred to ICU through this system have got one. What happens to them? Well, they're much less likely to go home afterwards. They are much more likely to go to a nursing home after their ICU referral, and they're much more likely to go to rehab, more likely to go to palliative care, and importantly, they're much more likely to die. 35% died in a year, 19% died in their hospital admission. These are terrible patients, all right? You knew that, but that's how it is. So that brings me to, should ICU own this? Christ, we own it. We started it. It's all up, all the usual suspects here, many of whom are in the room and are at this conference. We did it. It is us. We've been driving it since the beginning. We've been organising the conferences. So we own it. But there's all this stuff about we're not going to do it. It's horrible. We hate it. It's the worst thing that's happened. ICU will never be the same. ICU will be destroyed. It'll be terrible. But the important thing is really not about the generation at the moment to say I was never trained for it. Yet you were never trained for it as an older intensivist. There's no doubt for it. But what about the younger generation? The younger generation can be a bit difficult. But what do they think? Because they matter. They're the people who are going to do this job for the next 20, 30 years. So we asked them a question through the college. New fellows who just qualified as new fellows, what do they think about MET? Love it. It's interesting, challenging, positive part of my work. Like it. Great for patients. We need to own it. Accept it. It's here to stay. We need to get on and do it properly. Or I hate it. It's awful. We should do everything possible to get out of it. Okay, what do you reckon? Well, there you are. Love it, like it, accept it, hate it. In fact, the love it's are twice as many as the hate it's. So there's twice as many people who love it and think it might be the best bit of what they do than hate it. But in the vast majority. So we look, 94% either love it, like it, or accept it. It's here to stay. Let's do it properly. Let's own it and do it properly. So should we seek to minimise cause and involvement, or should we encourage cause? Because if we encourage cause, we can maximise the effect, because we want to be careful we don't underdose it. It's like antibiotic. You underdose it, worthless. Justify our staffing, maintain funding and protect staff. Because if we try and minimise it, then who's going to do it? The intensivist is still going to get called. The intensive care registrar and consultant still be involved. It's just that we won't be funded for it. Having a system there is necessary. And there are a lot of calls. It's not an easy thing, and it needs to be done properly. The other thing that I find very important is that for my career, I've spent such a long time talking to junior doctors who've been associated with patients who have deteriorated, have not been acted on, and have died. They are devastated. And they tried to escalate it and they couldn't. We are protecting doctors, junior doctors, by putting this around them. The system has withdrawn from them. The cardiologists are out catheterizing everybody. The gastroenterologists are scoping everybody. No one's around to help them. They're on their own. They're damaged. The system is wonderful for protecting them. And nurses as well. Nurses who say, I knew they were sick, I knew they were sick, I knew they were sick, I kept calling, no one did anything. These are damaged people. We have a responsibility to them. So I think ownership is important. We need to recognise it. We need to recognise it that we're doing it in intensive care. Perhaps it's part of our medical rotation. We make people do medicine, maybe doing... I think, personally, doing Deteriorating Patient teaches you more medicine. It's the bit of medicine I enjoyed. It's why I stopped doing medicine and did intensive care. It's the fun bit. So we can call it medicine and do it. We need it in our curriculum, teaching and examination. Own it. We need specific teaching materials, and I'll come to that in a moment. We need a redundant system so that when there's several MET calls at once, there's enough people around to do it. I did a ward round the other day. We had no MET registrar, as usual. 4 calls during the round. It was a difficult round. I had to go to 2 of them to help out as well. Our ward round was a shambles, and those patients were in ICU, got a very poor deal. We need to separate the two. Trying to say ICU has so much laxity that we can just do this massive thing is stupid and wrong. We need it done properly. We need specialist funded EFT, because no other service has ever been introduced without any consultant support. If you can think of it, tell me, but I can't think of it. Now, ED without consultants, surgery without consultants, oncology without consultants. Funded nurses, do it properly. Fund the nurses. Not 24 hours, need it properly. And junior doctors, that aren't trying to do ICU as well. So in terms of the specific teaching materials, it's apologies to Tally and O'Connor, but we need the book, Effectively Managing Critical Deterioration, a Systematic Approach. Your name here. Somebody in this room can write this book. We need several books. We need a curriculum. Everybody else has got books. There's books on the shelves for all of the different things. Textbooks. Where's the textbook for us? We haven't got a textbook. You haven't got a textbook, you don't exist. All right? So, a MET call to, just to give you an example of what I think it should look like, a MET call to CCU that I went to last week, a shock patient who had a pacemaker inserted 1 hour earlier. I went with my registrar, and she picked these 3 things as the things she thought it could be, or as most likely probabilities. I must say, the cardiology registrar was thinking about myocardial infarction and sepsis. All right? So he looked at this. He thought, not capturing, had a look, and immediately saw that it was capturing on the screen. That took 2 milliseconds. Tension pneumothorax. She had to listen to the chest, and it looked fine, and it sounded fine. She got the echo machine and put it on the chest. She put it on the chest and showed that they'd just confirmed her pneumothorax, slid it down the bottom, had a look at the... how can I make that click on this? Can you click the video and make it play for me? Anyway, all right, it's gone. It goes obvious tamponade. And then she said to the cardiologist, do you want to drain it or do you want me to drain it? And he said, I'd like you to drain it. And she did. and we were back in ICU within 20 minutes. All right? That's what a MEC call is. So I think avoidable cardiac arrest is indefensible. Prevention of disaster through effective deteriorating systems offer more value to hospitals and the system than even the most fabulous ICU. We're always behind the ball in ICU. This is the future. This is where the value is. It's required in Standard 9, but of course it's Standard 8 now. Rob's ahead of me. Hospital-acquired complications, threat of them being unfunded. Christ, hospitals need this. And hospital insurance risks and not preventing, this is going to be the future. We're not going to be allowed to get away with this. We're putting in minimum standards for intensive care unit-based rapid response systems in response to the ANZIC's College report, and we need to have these standards and put them in. The important thing, though, now is that it's not formally part of our training, and because it's not part of our training, the college is a training organisation. In order to go to hospitals and say you've got to do it properly, it's got to be in our training. So we've got to catch. We need to make this part of our training, and we need to own it, and once we've done that, then we can start to ask hospitals to do it properly. At the moment, they're ticking the box to say they've got a deteriorating response system, and I think in most cases they have got it, but it's half-assed and it's half-funded. We've got to do it properly, and because it's something they desperately need, I think that they should be listening to us. And ICU has come an awful long way since here, and Daryl says that deteriorating patients been around for a long time, but actually it hasn't. ICU has gone from this to this, from the 1960s to now, 50 years. Deteriorating patients only been around for 10. We've got a long way to go, but we've made a fabulous start. We've got a lot further than that in the first 10 years.